Assalamu alaikum dear students. Today our topic is the hepatoportal venous system. In this topic we will study the formation, tributaries and clinical significance of the hepatoportal venous system. The hepatoportal venous system consists of the portal vein and its tributaries. The portal vein is 3 inches in length and it collects blood from the abdominal and pelvic part of the alimentary tract except the lower part of the anal canal from the gallbladder, the pancreas and spleen, and transport this blood to the liver. The portal vein is formed behind the neck of the pancreas by the union of superior mesenteric vein and the splenic vein at the level of L2 vertebra. It then runs upward behind the first part of the duodenum. The first part of the duodenum will be like this, and it will runs upward behind the first part of the duodenum. It runs upward behind the first part of the duodenum and then pass through the free margin of the lesser omentum to reach the porta hepatis, where it divides into a left and a right branch. The right branch of the portal vein is shorter and wider, and after receiving the cystic vein, it enters the right lobe of the liver. Here only the sinusoids of the right lobe of the liver are shown. The left branch is longer and narrower, and after receiving blood from the para-umbilical veins and joining the ligamentum teres and ligamentum venosum, it enters the left lobe of the liver. Here only the sinusoids of the left lobe of the liver are shown. The ligamentum teres is the remnant of the left umbilical vein, and the ligamentum venosum is the remnant of the ductus venosus. The para-umbilical veins runs along with the ligamentum teres in the falciform ligament. The intrahepatic course. After entering the liver, each branch of the portal vein divide and redivide like those of the hepatic artery to end ultimately into the hepatic sinusoids. Here the portal venous blood mixes with the hepatic arterial blood and is separated from the liver cell by a single layer of phagocytic and fenestrated epithelium. From the hepatic sinusoids, the blood is drained through the hepatic veins into the inferior vena cava. Now, tributaries of the portal vein. Splenic vein is one of the formative tributary of the portal vein, and superior mesenteric vein is another formative tributary of the portal vein. The superior pancreatico-duodenal vein joins the portal vein behind the first part of the duodenum. The left gastric vein and the right gastric vein joins the portal vein at the free margin of the lesser omentum. The left gastric vein at the cardiac end of the stomach receives few esophageal veins from the lower end of the esophagus. The right gastric vein receives the prepyloric vein, which runs vertically in front of the pylorus. The cystic vein joins the right branch of the portal vein before it enters the right lobe of the liver. The para-umbilical veins, along with the ligamentum teres, runs in the falciform ligament and join the left branch of the portal vein before it enters the left lobe of the liver. This is the left gastric vein entering the portal vein. This is the right gastric vein which receives the prepyloric vein of mu and enters the portal vein. And this is the superior pancreatico-duodenal vein, which enters the portal vein behind the first part of the duodenum. There are many sites in the abdominopelvic cavity where anastomosis exists between the portal and systemic venous systems. This is systemic venous system is also called caval venous system. So anastomosis between the portal and caval venous system. Anastomosis between the portal and caval venous system. So these are the sites of anastomosis between the portal and caval venous system. These communications between the veins of the portal and caval venous systems, they form important routes of collateral circulation in case of portal obstruction. When there is obstruction to the flow of portal blood, what happens? These anastomoses act as important route of collateral circulation. The important sites of portocaval anastomosis are at the lower end of the esophagus, anal canal, in the region of the umbilicus, at the bare area of the liver, and between the colic veins and the renal veins. Between the colic veins and the renal veins. Between the colic veins and renal veins. So these are the important sites of portocaval anastomosis. Portocaval anastomosis in the region of umbilicus. Here the left branch of the portal vein through the para-umbilical veins communicate with the superficial veins of the anterior abdominal wall around the umbilicus. In portal hypertension, when there is obstruction to the flow of portal blood, the blood pressure in the portal vein rises. So in portal hypertension, these veins around the umbilicus become distended and tortuous. These distended and tortuous veins become prominent and are called the caput medusae. And this is a diagnostic sign. This is a diagnostic sign for the clinicians. These are the distended tortuous veins around the umbilicus, and this is called the caput medusae. This occurs in portal hypertension. Portocaval anastomosis at the lower end of the esophagus. Here the esophageal tributaries of the left gastric vein anastomose with the esophageal tributaries of the accessory hemiazygous vein. In portal obstruction, these collateral channels become distended and tortuous, forming esophageal varices, which may rupture, causing hematemesis, that is, vomiting of blood, and may even lead to death if there is excessive bleeding. Portocaval anastomosis in the region of anal canal. Here the superior rectal vein anastomoses with the middle rectal vein and inferior rectal vein. The distension and dilatation of these anastomotic venous channels results in the formation of hemorrhoids or piles, which may be responsible for repeated bleeding per annum. Portocaval anastomosis at the bare area of the liver is between the hepatic venules, the phrenic veins, and the intercostal veins. Obstruction to the portal vein or its branches leads to increase in the portal venous pressure called portal hypertension, which leads to enlargement of these anastomotic venous channels, which results in the formation of esophageal varices, hemorrhoids, caput medusae, and enlargement of the spleen called splenomegaly. The common cause of the portal hypertension is cirrhosis of the liver.